And now it's my privilege to introduce Dr. Song, who is our speaker tonight on advancements in neoadjuvant therapy. Dr. Song is an associate professor in the Department of Medicine at the University of Ottawa and a medical oncologist at the Ottawa Cancer Centre. She is dedicated to advancing therapeutic options for patients with breast and skin cancers, focusing on optimizing treatment efficacy and quality of life. Dr. Song's research emphasizes survivorship care, striving to improve long-term health and support for cancer patients post-treatment. She is also committed to enhancing medical education to prepare future oncologists with the latest advancements in patient-centered care. Dr. Song, over to you.
So good evening, everyone. Thank you for joining me for this educational webinar on advancement in neoadjuvant treatment. So here is my conflict of interest disclosures. So for today's session, I wanted to discuss the scientific rationale for neoadjuvant treatment approach, as well as some of the current data for high-risk melanoma. We also want to discuss the shift in paradigm with clinical use of a neoadjuvant treatment and future research directions. So before we begin, a little bit on the statistics. So in 2023, the estimated new melanoma diagnosis is around 9,700 cases. About 1,250 patients will die from this disease in Canada. The incidence of melanoma is still increasing by around 2% annually, but the mortality is decreasing. For a patient who has a diagnosis in the early stage, melanoma is still a highly curable disease. However, patients with clinical stage 3 melanoma has a high risk of relapse of 50 to 70% with surgery alone. And those patients with high-risk stage 2 melanoma also has high risk for disease recurrence if only treated by surgery. So over the years, there has been significant advancement in the treatment of melanoma. We began with chemotherapy using dacarbazine in the 1970s. And this agent really has a very little benefit in controlling melanoma. And then we had adjuvant interferon approval for prevention treatment in the 1990s. However, with the toxicity and the lack of overall survival benefit, it's not frequently or routinely used. What really made a huge difference in melanoma survival is since the development of immune checkpoint inhibitors, such as CTLA-4 and anti-PD-1 started in around 2011. And then since then, there has been multiple clinical trials looking at treatment using checkpoint inhibitors as well as targeted therapy for patients with metastatic melanoma. And we recently actually had approval of nivolumab and relatlimab, which is a nivolumab anti-PD-1 plus LAG-3 inhibitor. So we've got more combinations of immunotherapy to offer our patients. And targeted therapy with BRAF and MEK combination has also demonstrated the efficacy in both advanced stage and adjuvant treatment. Some of the key agents that we're using as prevention, including anti-PD-1 immunotherapy, so nivolumab and pembrolizumab, and the dabrafenib and trametinib are the targeted combinations. So these are frequently used agents as a preventative therapy in the high-risk setting. So before we get into our discussion, I just want to discuss the terminology. So immunotherapy is aimed to leverage the host immune system to better fight cancer. For adjuvant immunotherapy, this is given after surgery and targets any remaining cancer cells that may have spread beyond the primary tumor site. And it can help consolidate the effects of surgery by boosting the immune system and recognizing the cancer cells and eliminate residual cancer cells. Whereas neoadjuvant immunotherapy is given before surgery, is aimed at shrinking tumor before surgery, so perhaps less invasive surgery can be done. The treatment will be exposed to a large number of tumor cells being present in the host. So we're hoping for a better and stronger immune response. And the response to these initial treatment can guide clinicians and patients regarding the patient's long-term prognosis. So currently, the standard treatment for high-risk melanoma is still frequently considered as an adjuvant treatment. So we have key landmark trials looking at immunotherapy and targeted therapy for patient with stage 3 melanoma. So the Keynote-054 compared pembrolizumab to placebo. Checkmate 238 compared nivolumab with ipilimumab, and the COMBI-AD compared dabrafenib trametinib for patient with a BRAF mutated melanoma. And these agents has demonstrated improvement in recurrence-free survival. However, if you look at the curves, even the top curve are demonstrating the treatment effect. The 3-year relapse-free survival is still under 70%. So this is still not optimal. We're aiming for 0 recurrences. We want everyone to have good survival after their cancer diagnosis. So we need to do better. So what are the current issues with the prevention adjuvant treatment? So if we look at the top curve, looking at all patients coming in with high-risk disease, we see that in those patients received placebo, there's 40% of patients who never will recur despite not on any treatment. However, the top part, there's still about 40% of patients who will recur even after 1 year of treatment. So really about 20% of patients truly had the benefit from their prevention therapy. The relative risk reduction is about 40%, but the absolute benefit is about 20%. And then everyone received treatment will be exposed to potential immunotherapy-related toxicities, and some of that can be permanent. So we need to do better. So here I'm showing you a diagram. On the top is the adjuvant approach, where tumor gets removed first, then immunotherapy given to patient. There are a limited number of tumor cells being present in the host. And so with that, we're hoping for immune response and tumor lymphocyte, T lymphocyte expansion. And with the stimulated immune system, the hope is long-term cancer control. On the bottom, this is where the tumor is in situ before surgery, immunotherapy infused. And we see with a larger amount of tumor antigens and some of the rare antigens, there perhaps there's a broader and a deeper T lymphocyte expansion. And the hope is that with a stronger immune response, we would see a better long-term cancer control with the neoadjuvant approach. So with that consideration, there's proof of concept OPASSN trial. It's a very small study, 10% each, 10 per patient each arm. So one arm went on to have surgery first, followed by immunotherapy using combination ipilimumab and nivolumab. And then the other arm had patient having immunotherapy 2 cycles before their surgery. Then they had surgery followed by 2 additional cycles of adjuvant treatment post-surgery. So as we can see from the bottom graph, that treatment seems to be in favor, or treatment outcome is in favor of the neoadjuvant approach, both in terms of relapse-free survival as well as overall survival. So then following along with that, the OPASSN Neo study looked at different dosing combinations. So they had the higher dose ipilimumab followed by the lower dose of ipilimumab, and then the sequential ipi and nivo treatment. So 3-arm study. And as you can see, all treated patients had a very good overall survival outcomes, and over 90% of the patients still at 3 years and alive. And then we can look at the bottom curve. So for patients who had an excellent response, they continue to do well with the recurrence, despite only receiving treatment before their surgery and not having any further adjuvant treatment. However, the ones that did not respond had a higher risk of recurrence. So this is a group that we would want to have more innovative approach. So comparing to the adjuvant treatment, when we actually can see the response, then it will help us selecting the patient who needs more treatment and offering patient who had great response and not to have further treatment so they don't have to be exposed to potential long-term side effects from therapy. Again, another smaller study looking at neoadjuvant LAG-3, so relatlimab and nivolumab. So patient received 2 cycles of combination immunotherapy again with a different combination, and then surgical resection followed by additional 10 months of treatment again. So this combination has demonstrated fairly excellent pathological response. If you can see, the major path response rate was 66%. So in that population, perhaps these patients really do not need further treatment. On this study, everyone got the additional 1 year of therapy. And what's also interesting to see is during the initial neoadjuvant phase, none of the patient developed significant side effects. So again, I think this is a promising regimen that should really be evaluated again as a potential neoadjuvant treatment regimen. So this is one of the key studies. So the SWOG 1801, it's a phase 2 study evaluating neoadjuvant pembrolizumab versus the adjuvant pembrolizumab. So all the patients on this trial received 1 year of immunotherapy using pembrolizumab. The adjuvant arm received all treatment after surgery. And the neoadjuvant arm had 3 cycles before surgery, followed by surgery, and then 15 cycles after surgery. So when we look at the results, the event-free survival, as you can see clearly, the neoadjuvant treatment arm had a favorable outcome with 72% event-free survival at 2 years versus 49% event-free survival if the treatment was done after surgery. We don't have survival outcomes yet, and so long-term follow-up is still pending. The one thing I want to highlight is that in the neoadjuvant group, so patient had the tumor in situ, they went on to receive therapy. There's about 12 patients who were not able to have surgery because of disease progression. So I think it is important to optimally select out the right patient population for neoadjuvant approach. So in this small cohort of patient, perhaps we actually needed a more aggressive approach, such as a combination therapy to help induce a quick response, and so they could actually go on to have surgical resection. So what's really exciting for our oncologists is the Nardina trial. This is our phase 3 trial comparing neoadjuvant ipilimumab and nivolumab versus adjuvant nivolumab. So this is for stage 3 melanoma, patients who are treatment naive, so they did not have any prior therapy for melanoma. They were randomized to receive 2 cycles of immunotherapy with ipilimumab and nivolumab, and then followed by surgical resection. When the patient had a major pathological response, meaning that we don't see any tumor on the surgical specimen, or there's less than 10% viable tumor, this cohort of patients did not go on to receive any further treatment. Whereas the patient who did not have a major pathological response, they either received additional 11 months of immunotherapy or went on to targeted therapy with dabrafenib, trametinib if they had a BRAF mutation. In the adjuvant arm, patient went on to have surgery, and then they had immunotherapy after surgery. So the study demonstrated improvement in event-free survival in favor of the neoadjuvant arm. So here with early follow-up at 1 year, we could see an 83% versus 57%. And distant metastases-free survival also is in favor of the neoadjuvant approach, so 88% versus 70%. So this study is actually considered practice changing. So hopefully we will be able to have drug funding and start using it as routine clinical practice. When they looked at response guided or response rate in terms of relapse risks, and so again, you can see in patient with major pathological response, very little, about 6% of people having recurrences around 18 months. Whereas if the patient did not have a good pathological response, there is a much higher rate of recurrence. So again, identifying the patient population that we would need to consider further innovative therapy after surgery. So based on all these clinical trial data that I've just showed you here, if we look at a summary, so single agent pembrolizumab versus combination relatlimab with nivo or ipi with nivo, what we can see here is the pathological response seems to be more in favor of combination immunotherapy. So patient had a higher chance of response. Perhaps slightly higher event-free survival at 2 years with the combination, so in the 80% range versus 72% with pembrolizumab. However, if we look at overall survival, there's actually not yet any significant difference between these neoadjuvant combinations. And if we look at toxicity, the single agent immunotherapy certainly is associated with a lower risk of side effects comparing to combination immunotherapy, with the exception of the LAG-3 nivo in the neoadjuvant setting. For that small trial, they did not observe any high risk side effects. So with all these data available as a clinician, if I'm facing the patient, would I offer that particular patient single agent immunotherapy or should we do combination immunotherapy? We don't really actually have a clear biomarker to guide me in that selection. So a lot of it become a discussion about response rate, about toxicity, and then sometimes patient preference can play a very important role in that decision making. So having a biomarker would be really ideal rather than making this sort of a patient choice or physician's choice. So some of the potential biomarkers as being evaluated, including the whole, so patient's phenotype, HLA type, the gut microbiome. We wanted to look at the tumor microenvironment, such as looking at interferon gamma signature, what is the tumor mutational burden, what about the CD8 cells within the tumor. We also want to look at tumor biology, right? Is there PD-L1 expression, and what is the epigenetic modifications or tumor mutation burden within the tumor as well. So some of these tumor biomarkers are being evaluated. However, none of these markers are currently being used as a standard approach in treatment selection. One of the more promising signature is interferon gamma. So if we can do this at baseline before patients start treatment, the interferon gamma high signature group, we see that there's actually no difference whether they had single agent immunotherapy versus combination. Whereas in the interferon gamma low signature, it definitely indicates that combination high dose ipilimumab will result in higher response rate. And that is also true for long-term event-free survival. In the interferon gamma high group, there is really no significant difference which immunotherapy we give patient, whereas in the interferon gamma low signature, we would want to consider more aggressive combination immunotherapy. So what do we know about the neoadjuvant approach? So we have very good scientific rationale and proven efficacy. We know that the response to initial treatment can predict long-term outcomes. We also know that response from immunotherapy in the neoadjuvant setting seems to be more durable than the targeted therapy. And it is feasible in clinic. However, we do need to have more standardized pathology evaluation, as this is very important for guiding clinicians in selecting adjuvant treatment. What we don't know, including we don't know exactly which drug to use or which drug combination to use. Is 2 cycles enough, or do we need 3, or is 1 good enough so we don't delay surgery for too long? what is the optimal duration for adjuvant treatment after surgery, and then who will be the patient that we can safely say you do not need further treatment, or maybe they don't even need surgery if we're not seeing any signs of cancer. So for the non-responders, I think we really need better treatment, more innovation to help reduce that risk for recurrence. And we do need a biomarker to guide clinicians in selecting out the treatment or the optimal treatment for each individual patients so we can minimize the toxicity and improve efficacy. So the request for neoadjuvant pembrolizumab was sent in December 2023. We had positive recommendation from CADIS in July. And recently, I know for Cancer Care Ontario, we have formal approval for neoadjuvant pembrolizumab since October 2024. And the neoadjuvant ipilimumab and nivolumab combination request was submitted in July after the recent ASCO meeting. And the first review will actually happen this week. So hopefully we'll have positive outcomes and that we can use this in real clinical practice. Some of the key things we have to consider when neoadjuvant treatment comes to clinic. So we would need streamlined referral process and timely imaging workup. So when patient comes from the surgeon to oncologist, we need the staging scan to be done so that we can offer the best treatment for these patients. Would be nice to have biomarkers so I can decide to give a single agent or a combination treatment. Our pathologist would have a lot of work to do to make sure we have a detailed and accurate report on path response. And again, for future adjuvant treatment, so in the in the PCR, so the major pathological response group, there's still a small number of patients who do recur. So would they actually benefited by a few additional cycles of treatment? And now, who are they? Is it going to be? Is there a biomarker that we can select them out? And then in the non-responders, what are some of the innovations that we can consider, right? Would they need triplet therapy or would they need combination targeted with immunotherapy? So that's still being determined. For optimal patient care, I've always emphasized that we need ongoing education. So we need to increase the awareness among referral physicians about the neoadjuvant approach. We want to select the right patient for the neoadjuvant treatment. So if someone has an autoimmune condition that can lead to significant toxicity if we give immunotherapy, or someone has an organ transplant, these are probably not ideal patient for neoadjuvant treatment. Patient education on neoadjuvant approach as well as toxicity management would be key to ensure stable quality of life or no significant severe toxicities in clinical practice. So quick look at what are some of the ongoing trials. And so there are currently some trials ongoing for high-risk stage 2 disease. We're also looking at targeted therapy with combination immunotherapy as a neoadjuvant approach. And there are some of the more innovative biomarkers being evaluated for immunotherapy in high-risk melanoma. Some of the Canadian effort that we're trying to look at, the optimal combination immune checkpoint inhibitors. Can we combine investigational agents with PD-1? Would the gut microbiome be an important area of research for us to evaluate? And how do we optimize the adjuvant treatment for both the good responders and the non-responders? So to end, I might show you this case. So 40-year-old young man with melanoma on his right leg, and he had a palpable right inguinal lymph node on presentation, and biopsy showed metastatic melanoma. He has a BRAF V600 mutation. Clinically, this is a stage 3 melanoma. He's otherwise healthy. So if we have access to all treatment options, what treatment would we recommend for him? So if we look at adjuvant approach, this patient will do surgery first, and he will have 1 year of treatment. So there'll be 9 to 17 infusion visits, depending on how frequently we give the infusion. And there will be additional clinical visits for patient to see their physician to make sure they are managing well with the side effects. Toxicity level is about 20%, and some of them, the toxicity will be non-reversible. And the cost of the drug for 1 year would be around 150 to 180K. If we look at neoadjuvant approach and we give them if this particular patient, 2 cycles of infusion with ipilimumab and nivolumab before surgery, we may see 40 to 55% of PCR, depending on which trial data we follow. The toxicity rate would be around 29% based on the trial results. The cost of the 2 cycles of drug, it would be around 29K for an 80-kilo person. And so half the patient who got the 2 cycles will not require further treatment. If there's still additional residual disease, the patient will continue with treatment to complete 1 year. If I had to talk to a patient about these 2 approaches, I think a lot of my patient would be in favor of a neoadjuvant approach. And I think this is what I would highly recommend as well, with all the current evidence and data supporting neoadjuvant therapy. Just to end, I think ultimately we want to personalize treatment for high-risk melanoma patients. So in the neoadjuvant approach, can we have a biomarker? So can we use interferon gamma as a routine practice? So then I can decide to give single agent or combination. We should continue to enroll patients to clinical trials evaluating neoadjuvant therapy. So if the patient had neoadjuvant therapy, so can we use other imaging method to determine if they had a good response or not a good response, such as a PET scan? If there's no metabolic activity, can we safely to say that particular patient may not require surgery? This is particularly important if the melanoma is in an area that cosmetic outcome could be important. So for patient who had a great response, but to select out those few percent of the patient who still can recur, could ctDNA be used after their treatment? So if they have negative ctDNA, we could just observe, and positive ctDNA, we might want to give more treatment. And the non-responders, we have a lot of discussion about personalized cancer vaccines. So can we use the residual tumor and develop a targeted vaccine for these patients? Would that be a better treatment option for them? And with all the technology, I think, big data, we really want to use the AI tools to guide physicians and patients to select out the best treatment for everyone.